Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening and welcome to Pause for the Truth. I am your co host, Jocelyn Turner. We are in Northeast Florida. And if you have been following the news at all today in the last 48 hours, you know that the state of Florida, especially some parts of the state of Florida, are bracing for Hurricane Milton. So prayerfully, it won't hit. And if it does not cause destruction nor loss of life. Before I continue, let me bring in my co host, Dr. Rogers Kane. How are you doing this evening, Dr. Kane?
I'm doing fine. Evacuate or die. That's what the narrative and the directive that received from the mayor of Tampa. Evacuate or die.
Is that right?
That's what she said, live and in color.
Wow. Wow, that's pretty extreme.
Yeah, that's what she said. It's been going across. But there's a level of truth to that because what Tampa is about to get hit. They got a little bit of shearing pressure to drop from a front coming in from the west. A little bit of upper level shearing pressure that did kind of drop the wind speed of the hurricane some, so that's good. Definitely dropped it it's going to drop it from a 4 to a 3 by the time it hit Tampa. But that still ain't nothing to sneeze at with Tampa the way it's set up.
Yeah, we always have to stay ready and be ready. You know what I mean? And just when you live in any part of the country, you are going to experience some type of weather occurrence. And here in Florida, obviously have to deal with hurricanes and tornadoes and things of that sort.
The mayor obviously took a course of live and let die. You know, if they don't want to get out of Dodge, she's not going to send her workforce in there and have her EMTs and those people die when they wouldn't have a choice. But these people got choices. So.
I think the one interesting thing that was interesting to me is the whole notion of lithium batteries, and if you have an electric battery up whatever car,
right,
not to keep it in the garage because it could, so that whole thing.
We had one right down the street from the house the other night.
Is that right?
People fire in the people's garage. So
yeah. Anyway,
that wasn't about the storm, but we wanted to warn our audience about it because that's what we try to do, keep them informed.
Absolutely, Dr. Kane. Well, if you know the third wheel of this podcast, that would be our technology wizard who comes from behind the scenes sometimes, and that is none other than Tyrone Jackson. How are you doing this evening, Tyrone?
I'm doing well. Thank you very much for asking, Miss Johnson. I'm on with a subject like this only for symmetrics. I wanted to have 4 people on screen instead of 3. I can't contribute much to this discussion. This is an opportunity for me to learn.
Very good.
Of course, we always enjoy having you, Tyrone. And our resident expert, drum roll, Dr. Kenneth Jones. How you doing, Dr. Jones?
I'm well, thank you.
Wonderful, wonderful. I tell you what, Dr. Jones has done so many surgeries, not so many, but a few surgery of my family members. And tonight we're talking about breast cancer from diagnosis to recovery. And I can tell you that Dr. Jones did my aunt's surgery years ago. I don't know if you remember it, but she was in her 80s when she was diagnosed with breast cancer. And that was a tough decision, Dr. Jones, rather, for my mother to make as her caregiver to help her decide what was the best treatment for her. So, Dr. Jones, can you give us a brief overview of breast cancer, what it is, how it develops, and and why early detection is so crucial.
Well, breast cancer, when we look at the actual histology of it, it's basically abnormalities in the tissue in the tissue of the breast, primarily the ducts of the breast. And breast cancers can go from early stage to late stage. Ideally, what I want to get across this evening is early detection. People who are detected very early, they have the best outcomes in the management of breast cancer. So when we look at we may hear somebody says, well, I have intraductal breast cancer. That's breast cancer that's still within the milk
ducts.
lactiferous ducts.
Yeah.
And I'm trying to keep this very basic and not take it very scientific.
But that call it milk ducts. The milk,
the milk ducts.
Right.
And within the breast tissue, that's the earliest possible stage of breast cancer. I have patients that I operated on in 1983 with intraductal breast cancer who is still alive today with no evidence of recurrent disease. So we go from that phase to patients with stage 4 disease, patients who show up with breast cancer already metastasized or already spread to the lymph nodes in the armpit, many times already spread to the lungs, spread to the bone, spread to the liver. That is not how we want to identify patients with breast cancer. So the most important part from the lady's perspective and her spouse or significant other is the breast self-examination. If someone has a history of breast cancer, then you are a family member with breast cancer, then we have to be a little bit more focused. You must get that mammogram. Now, there are areas where if you have a family member who has, say, your mother had breast cancer, her mother had breast cancer, her sisters had breast cancer, those ladies, say you are a daughter of that mother, then you should probably be getting your baseline mammogram much earlier. And that is something you discuss with your primary care physician. But if you've had no family members with breast cancer, you must still continue your breast self-exam. Don't wait until you're 40 to do breast self-examination. Start in the at 30. So you will know what your breast feels like, or your significant other would know what your breast feels like. So if they detect a change, you could say, this is not how it felt last month or 2 months ago. I should get a mammogram.
Dr. John, what's the youngest patient you ever had with breast cancer?
23.
Is that right?
I'm one up on you. I had 119.
Yep.
Wow.
I mean, they're that young now. Yeah. And there's a whole discussion about that. Why is it that we've seen this jump in early stage breast cancer over the last 15 to 20 years? Is it that? And there are some things about it. One is the longer exposure to estrogen. And what they're saying is a lot of young ladies are starting menses earlier and delaying having kids into their late 30s, sometimes early 40s. And that longer exposure to the estrogen cycles, they're thinking that that's one of the contributing factors. Because historically, many ladies will have their first child at 19 and 20 in the old days. Yeah. But of course, now, as ladies become more educated, they have careers, they've got to go after their careers. You can't stop to have a baby at 19 or 20. Many people wait until they've reached the level of their career that they want and then have a child. So many times that may be one of the reasons. There's some association with high concentrations of alcohol use and breast cancer. there's definitely a relationship between obesity and breast cancer and the type of fat that one sees in the breast and in the tissue. So there are a number of reasons. There are things, what things can we do, or the family or the lady, is look at those things: fat consumption, fat overall, BMI or body mass, alcohol use, smoking. Those are things. Now, can I tell you that let's follow a group of ladies who just smoked and say that they get breast cancer ahead of someone else? The data is not as strong, but there is some data that people think it may be. The most important that we know of for a fact is the obesity one. That one we know.
Let me. So when I was doing, early in my days when I was doing a whole lot of gynecology related stuff, which included breast exams, yada yada yada. The rule of thumb at that time, women who had kids after 28, the age of about 28, had a higher risk for breast cancer. That's still kind of a
about 30. The number is about 30 now.
About 30 now. They went up to 30. What about the role that steroids in our food consumption may play?
Well, we don't have that data yet.
Right.
The question is, people are saying, why are young people getting cancers? Historically, young people, and I could stretch this out to colon cancer.
Right.
I could stretch this out: breast cancer, colon cancer. Many of those environmental factor type cancers, we're seeing a higher incidence in younger people. Historically, 30-year-old males or females didn't get colon cancer, but now they're getting it. Is it that we've changed so dramatically what we eat? We don't know.
What's given to us,
chemicals they're putting on the food that we're eating. I mean, one can make the assumption that it could be, but no one will do that study where they say, we're going to feed you whatever food laced with this chemical and see 10 years later if you get cancer. That's not going to happen. And so a lot of it could be diet related and what we eat and what we're inhaling. But we know there's an increased incidence of cancers across the board in younger people in the United States.
So, Dr. Jones, what are some common misconceptions or myths about breast cancer that you encountered when working with patients?
One of the first things is when I see someone who comes in with a large breast cancer, it's obviously that it's there. I mean, there's no hiding it. Why didn't you come earlier? Well, I heard if they cut into it and air gets on it, it's going to fly all over your body. That is not so. And then people get these anecdotal experiences where I had a friend who had a mass, and once they cut the mass, within 6 months she was dead. Well, the reason it was so large it had already spread all over the body.
I sent you one.
The most important thing is early detection. Right. Get that annual mammogram. Now, what we have found is that since the onset of the Affordable Care Act products that are out there, we're seeing more people being diagnosed because now these people have access to health care. Prior to the Affordable Care Act, if you didn't have insurance or you couldn't afford it, there were avenues for ladies to get free mammograms. I know Ascension Healthcare has a van, Baptist has a van that goes out into the communities and do screening mammograms. Now, there's a difference. When you get a screening mammogram, it may show something. Now you need a diagnostic mammogram, which is usually 3D tomosynthesis that includes a mammogram and ultrasound. That is not usually offered in the van. Now, some vans may upgrade to tomosynthesis for screening mammograms. And many times when you do a diagnostic, there's a physician there doing a clinical examination of the breast. So you're getting all of that as part of the diagnostic process.
What's the tomosynthesis? What's tomosynthesis?
It's a 3D form of breast evaluation. So when you order a mammogram today, it's all 3D mammogram, which is the same as a Tomos, because basically it's narrower cuts in a more 3D dimension.
Dimensions.
So when they look at the breast, it
Mammogram
gives you more detail.
The mammogram we used to have before was just like those old-fashioned ones you throw up on the
Right.
white light, and
Right.
it's 2D.
But now,
You know, it's
now
Well, Dr.
we're really going after a more detailed evaluation.
I can tell you, Dr. Jones, I had a diagnostic. Ooh wee! I cried like a baby because I didn't know. I had never had one like that where I had to stand there for a few minutes. Can you explain? Because I was totally lost when they were talking about looking for calcification, and what's the significance of that?
Well, many times the earliest stage of breast cancer is identified on the mammogram as what's called microcalcifications. Those are cancer cells that have died. So they become filled with calcium. That's the basic way to say it, actually. So if you get a routine mammogram and they see microcalcifications, you will get a diagnostic mammogram after that. And what they're looking at is any microcalcification, the probability that you'll end up with a core biopsy, a needle biopsy, is very high. Because microcalcifications many times are the earliest stage that one can see on a mammogram that says this person may have early stage breast cancer, which is ductal carcinoma in situ, or early stage invasive breast cancer, which is.
let me throw in a little bit of just for FYI. The let patients know, that's what I have to tell my patients. When the body gets damaged in one form or fashion, one of the ways it repairs itself, it sends calcium into all the damaged tissues. And so when you having cancer, that's damaged tissue. Surrounding tissues may be damaged. So that's why you tend to see a lot of calcification of calcium.
Right. In the breast. And it's usually micro.
Right.
Now there's micro and macro. For instance, if you were wearing a seatbelt, got into an accident, and you had some bleeding in your breast, those calcium chunks are bigger when it heals. The micro, the little tiny ones that sometimes after the mammogram, you have to do magnification to see them. Those we send for biopsy. Now, the biopsy that's done, and ladies need to understand this, there are two ways they can do the biopsy. They can use an ultrasound to identify the site, and then they put the needle in. The other way is called stereotactic, where you lie on a table. It has an opening in the table. The breast is through there. And the computer actually reads the mammogram and decides exactly the depth of where the needle goes in. And you press a button, it goes in, takes some of the tissue and come back out. You could do that 1 or 2 or 3 times. So there are two ways. Now, the one area we didn't talk about is for the ladies who have very dense breasts, who may have a family history, a strong family history of breast cancer, or they may be BRCA, the BRCA gene, BRCA gene positive. Those ladies many times get an MRI of the breast because that will give you more clarity when you look at that breast. There may be something there that may need to be biopsied that was not picked up on the mammogram. So on sensitivity, it's very sensitive.
So when it comes to, I'm sorry.
No, that's fine.
Dr. Jones, when it comes to early detection, what advice would you give to our audience who may be apprehensive about getting screened?
The most important is earlier any breast cancer is detected, the best chance you have of long-term survival. And we see this a lot in ladies between the age of 30 and 40. They're busy, they're raising children, they forget to do their mammogram. And then by the time they go, they've got a mass. And by the time that's biopsied, it's invasive cancer. Now, one of the things we do with every breast cancer, we check it to see whether it likes the environment of estrogen and progesterone. So the ER positive or negative, PR positive or negative, or it's human epidermoid, well, the HER2. You see people always talk about HER2. It
Yes.
can either be HER2 positive or HER2 negative. Now, I say this because within the African diaspora, especially African Americans, we know that data, there's a higher incidence of triple negative breast cancer. What does that mean? That the tumor that you have is not influenced in any way by estrogen. And the HER2 is also negative. So that human epidermoid receptor factor that you have, you don't have it. So what does that mean? It changes the medicines you can be treated with. Practically every lady with triple negative breast cancer, remember what this means: estrogen receptor negative, progesterone receptor negative, HER2 negative, they all get chemotherapy.
Mm.
Now, there are patients who have breast cancers that are estrogen receptor positive, who are progesterone receptor positive, that we can send those tumors off for molecular genetics. And it may come back that those tumors, when you look at them, they could do just as well with an anti-estrogen pill. And I'll just throw out one. People have heard of tamoxifen. They've heard of aromatase inhibitors, which is another anti-estrogen tablet. And they can be treated with those tablets and don't need chemotherapy, because the molecular genetics of the tumor says if you give this person chemotherapy, it's not going to make a difference on local recurrence or distant recurrence. So we have that available for people who are estrogen receptor positive, progesterone receptor positive. But people who are estrogen receptor negative, progesterone receptor negative, HER2 negative, they all get chemotherapy.
Joe, you just touched on, you went on ahead and touched on the racial differences again, in terms of, you were saying those that are triple negative, and Black women tend to be more aggressive cancer, is what you were saying?
Yes, they are
Okay.
more aggressive cancers.
They're more aggressive cancer.
Yes.
So, and when and those are the ones that we want to detect as early as we can, correct?
Yes,
Okay. And
absolutely.
okay, and then they're more likely to be the ones, I just kind of want to summarize. They're the ones that most likely will benefit from chemo.
Well, if they're triple negative, yes.
Right, if they're triple negative. Okay. So, because I know women are very afraid to hear the word chemo.
Exactly.
For many reasons, and justifiable reasons. I can be afraid too, but
one of the things you mentioned when you said the word genetics, I was just thinking, having been involved recently in a study about genetic testing, is that ever recommended, or is that what BRCA is? Is it a genetic test to determine one's risk for developing breast cancer?
Well, there are a number of tests that can be done that would say that if this person with this genetic, they look at genetic abnormalities, would put them at a higher chance of developing breast cancer. If you are BRCA positive, BRCA1, BRCA2, you're at a higher risk of developing, this is say a 30-year-old, doesn't have any breast cancer, but because her grandmother, her mother, her mother's sister, and her sister had breast cancer, they may evaluate her genetically to see if she's carrying any of the genes. Many times, if they are carrying the BRCA gene, the question is, what do we do? So you're carrying a gene that puts you at risk of developing breast cancer and ovarian cancer. So what do we do? Many of those people opt to have bilateral prophylactic mastectomies. And if they're past childbearing age, they will opt to have a hysterectomy with removing the ovaries also. So
Wow.
that's the other end of having those genes. And, we could go over here and list them, but I think for the general population, what they need to know is if you carry those genes and you're at risk, you do have options. It's not like, oh my goodness, I have the gene. I know I'm going to get cancer. So what? No,
Mhm.
they have options.
Do you encourage genetic testing?
The ladies with triple negative disease, we do a lot, yes.
Well, joining us now is Monique Blue. How you doing, Monique?
I'm doing great, thank you. Thank you for having
Wonderful,
me again.
wonderful. You out in the streets getting your hurricane supplies?
Getting what's left. Getting
Wish
what's
you
left.
could tell
Yeah,
that
right.
when Dixie signed behind her. Huh?
Yep, I had to run back out. I was like, oh, wait a minute.
Yeah,
Yes.
that's good. We all good.
Well, I wanna pause for a moment to for Monique to just share a little bit about yourself and why I asked you to join us on the podcast this evening. I'm gonna let you tell your story.
Okay. My name is Monique Blue. I was diagnosed exactly 5 years ago this time. This is my fifth year, so they say that this means that you're out of remission, but you all know that once you have had breast cancer or any cancer, you're never really out of anything. When I was diagnosed, I found out because I had a lump on my right breast and went to see about it at the hospital, and it turned out to be the left breast that actually had the cancer in it.
Mm.
I had went to several doctors because the first doctor said I had to act fast. I didn't have a lot of time. I was stage 2, but they said it could grow. So the first doctor at the first hospital, which I will not name, suggested that I just remove the cancer and keep my breast to just take the tissue out. And I said, what are the chances of this happening again if that's what I was to do? Well, we can study it, we can test you, and we can see, but you should be fine. It's the same chances almost if you was to get a mastectomy. It's a 3% difference. And I then went to another doctor at another hospital and I said, I don't want my breast at all. And this is the decision. I don't want anyone to change my mind. Because to go through something like that at what I consider would be, the young age of 48, it's a lot. It's a lot when you are an African American woman and there are not that many resources out there other than the ones that you hear from people, or then you start to educate yourself. And you start thinking about the history of so many Black women that didn't get tested or that died from breast cancer. And we're in a new time now where you don't have to die. It's not a death sentence. And that's one of the things that I try to educate women on, that I speak to through my foundation. This is not a death sentence, but to find out about it in the beginning, it almost feels like what is going to happen to my life. After having a double mastectomy, I did chemo. I did chemo for a year, and it's life changing, but it is better to be on this side to share, educate, and empower those that are going through it than to be on the other.
Yeah, I remember when Monique shared her diagnosis with me. I was in shock, and you almost don't know what to say. But I am happy. And I remember when she was diagnosed, and 5 years later, to see the work that she's done and become an advocate for it, and her Queen
Big
Bee
Queen B.
Foundation and the work she's doing. So it is fantastic.
Thank you.
Monique, how difficult was it for you, and I say as a young woman, to decide to have a double mastectomy? Or was it easy, a no-brainer for you because you didn't want to have to go through that again, as you said?
Well, I think that the time that I was at in my life was a very stressful time. And I had a lot of different variables, a lot of things happening. I lost a relationship. I just started my job again. My dad had just passed a year before, and so I just kind of felt like at this point I had to figure out how to take care and preserve me. And it was hard at first because I had the mindset of I'm fairly young. I still want to meet people. What is somebody going to say if if I have a mastectomy, or if my implants don't look right, if I don't get implants? And then I had to trust. I had to trust God and know that it's the best thing for you, and you'll be able to tell the story. And I always told people, being in the entertainment business, I had clients that I shared the story with, and told them when I was sick, and one lady cried so hard that it scared me. And the first thing she said was, "Well, my mother died of breast cancer, and you're such a good person. I can't believe this is happening to you." And when
Mm,
she said that to me, I said, "If not me, then who?" And
mm,
that was kind of a wake up call for me, because what makes me any different, because I am an advocate for so many other things, and I was already doing Sister Strut and promoting awareness with breast cancer, and also, mothers against violence, and mad dads. I did so much in the community, but I said, what makes me any different? And maybe this was another part of my journey, of the message that I was supposed to tell. Maybe this was something else. Maybe the things that I thought that I should have and was going right or was going wrong was not really what God wanted me to talk about,
yeah,
you know?
yeah, yeah.
So
Dr.
it was
Jones,
difficult, but it was meaningful, and it had a
yeah.
purpose behind it for others.
Wow. Dr. Jones, what are the most common types of breast cancer surgeries, and how do you help patients decide between lumpectomy, mastectomy, or reconstruction?
Well, going back to now, I've been doing breast surgery for 48 years,
Mm,
and we've gone through where the diagnosis of breast cancer, you automatically got a mastectomy. And scientists and surgeons and everyone involved in the care decide to say, well, let's see, are people doing any better with a mastectomy for breast cancer, depending on the stage, say stage 1 or 2 breast cancer, as opposed to doing a lumpectomy, keeping the breast tissue and radiating it? Now, the data has changed a bit. In the old days, we see the lump, we do the mammogram, we take the lump out. The person could have additional cancer somewhere else in that breast or the opposite breast. So that's why we do MRIs on everyone now who's diagnosed with breast cancer. Especially, there are different types. There's invasive mammary, there's lobular carcinoma, invasive lobular, there are different types. We're not going to go into that detail on the pathology, but when we do that bilateral mammogram, it's part of the planning process. And we could tell the patient, based on the data we have, that we can do a lumpectomy and you'll need radiation after. You may or may not need chemotherapy, but if you have an estrogen receptor positive tumor, there is medications we can give you that go along with that. Now, that data, initially, a lot of people backed up against that data, but now the data is pretty well documented and well researched that yes, for certain stages of breast cancer, a lumpectomy does just as well. But by doing a lumpectomy, you have to have radiation. Now, some ladies come in and say, I don't want these anymore. I want you to take them out. Then we discuss nipple sparing and immediate reconstruction. So I work with plastic surgeons who do the immediate reconstruction. So we would do the bilateral mastectomy, and then the plastic surgeon will come in and do the rebuilding. So there's some ladies who said, I don't want to lose my breast at all. So those patients, they get a lumpectomy, but they know they have to have radiation after. And medicine, whether it's going to be chemo or just the aromatase inhibitor or the anti-estrogen medicine. Now, there's, as I said before, we do molecular genetics on all breast cancers now to tell us whether this cancer is the type of cancer that doesn't need chemo or needs chemo. So that's the level we have come to now in looking now at the molecular genetics of the tumor. Now, as I said earlier, I have patients I did lumpectomies on in 1983 that are still alive and well with no evidence of breast cancer.
Mm.
I've had patients that I've had to do radical mastectomies on, which is the old-fashioned removing the muscle, putting a skin graft. I have a lady now, she's 1986, and she's still alive with no evidence of disease and nothing in the other breast. So it's all different for different patients. Now, I've always asked the ladies, and I'm, one of the groups here is called Sisters Network. It's an organization of African American women who have breast cancer, who have been treated, who are going through treatment, and they communicate with each other, a support mechanism to help them understand what they're going through. And many of those ladies, they will tell you it's good to speak to another lady who has been going through the treatment. What is it like? The hair loss. Yes, a lot of the chemotherapy will result in hair loss. A lot of the chemotherapy will result in numbness of the fingertips, changes in the color of their fingernails. They'll get these black nails. But once the chemo is finished, it goes away, the hair grows back. So my most frequent operation is probably a lumpectomy with evaluation of the lymph node. Now, if you have invasive breast cancer, that's the tumor we said grew out of the duct, we always sample the lymph node at the same time. There's some data now that is saying if the lady's over 75 years of age, she may not need to have her lymph node evaluated. All of that is still ongoing information. But the most important is understanding whatever you and the family member choose to do, and we participate in that care, we have to follow you. If you have your breast, you have to be followed. Every 6 months, usually after you receive radiation therapy, and then the surgeon may see you once a year. But the radiation oncologist and the medical oncologist may see you, every 6 months. There's some institutions that have a chemotherapy department where they only treat breast cancer. And after they're finished treating the breast cancer, they may be followed by breast health, which is another division. Or if they don't need chemotherapy, they're not followed by the chemotherapy people. They're followed by doctors who just take care of breast care without surgery many times. So there are a number of different things available to ladies today. But the most important is making the diagnosis early. And once you have an early diagnosis, you have more choices. That's what I tell people. If you have an early stage diagnosis, you have a myriad of choices. You may not even need chemotherapy, depending on the tumor, of course, because now we do molecular genetics. In the old days, everyone got chemotherapy if you had breast cancer. We don't do that anymore. We do molecular genetics.
Dr. Kane, I don't know if you want to say something, but you're muted. And I don't know, once you finish your comment, then we'll do some troubleshooting with Monique, and then we will go to our history maker moment. Yes.
Okay. Yeah. What I was going to say is, the one thing that Ken is saying repeatedly, and that I gather from this, is that instead of treating breast cancer like we did in the old days with a broad brush, or one medication or one whatever approach, one approach fit all is what we do. Now it's specific for the individual, and they have many tools that go and look at what this individual is all about. Kind of like doing a fingerprint to see, because you're unique. And so we take a look at what's going on with you and what kind of breast cancer you have and what kind of positive or not or negative receptors you have, where it's located. You take the person, you look at a picture of them and you cater your treatment to that individual. And that's
Right.
what I want ladies to make sure
That's
they
true.
understand.
All treatment is tailored to the individual person with breast cancer now.
Right.
We don't just show up and say, oh, you need a mastectomy, or oh, you need this. But
Right.
you may have a very small tumor, but they do genetic testing on you, and your mom, when you did the family history, you end up being BRCA positive. That
Right.
totally changes everything.
Yes.
You know, they may need to have what Angelina Jolie did. She went ahead and had bilateral mastectomies, total abdominal hysterectomy, bilateral oophorectomy. She had the whole works done because
Wow.
she knew she was at a high risk of developing ovarian cancer with her genetic abnormality. So, as I said, we tailor care now to the individual patient. Everyone does not get the same treatment.
Same thing. Monique, well, welcome back. I wanted to ask you because I noticed your reaction as Dr. Jones was talking. So, what was the experience of deciding on surgery like for you? Did you opt for reconstruction, and what factors influenced your decision?
I did opt for reconstruction, and I'm going to tell you why. And it was something very unique that Dr. Jones just said. And I'm sure he may know that a lot of the other doctors don't do that. When they told me the process, as far as saying that they would remove the breast, they would clean everything out, and then the next surgeon would come in and put in the implants. And I would not have to go through spacers and constant coming back and just more and more and more visits in the process of it while mentally trying to handle it. I said, you know what, that would make it a lot easier for me. And so therefore, that's what I'll go with. But I have cases of people that join the foundation, and that's not their story. That's not what they're telling me. And I don't say any different, but they're like, oh, I have to get the spacers, then I have to go back and get this, then I have to go back and get that. And I'm wondering for Dr. Jones, like for me, this was the best experience ever to just get everything done and do my chemo and then start working on the healing process of the body and mentally and spiritually. But as far as other doctors that have you come back and get spacers, why is that another way of doing it with having the client, this patient constantly come back and have to go through surgeries as opposed to the way that you did? Does that depend on the
Well,
person?
usually what we do is if I have a patient that needs a mastectomy, I immediately send them to the plastic surgeon because I want to know that that plastic surgeon has seen this patient and feels comfortable with doing an immediate reconstruction because I prefer the immediate reconstruction. Now, we have to remember not all immediate reconstruction have implants. We do what's called a DEEP, which is a deep inferior epigastric perforator. They take actually, the ladies get a tummy tuck at the same time. They take the fat from the middle portion of the abdomen with the blood supply. So it has an artery and a vein attached to it. That's the deep inferior epigastric perforator. And they bring it up to the chest. And along in here, you have a big artery and a vein, the intercostals, and they anastomose it in there. And that tissue feels exactly like a breast because it's your own tissue. It's not anything plastic. And then they come back later and they can do like a 3D tattoo for the nipple and areola complex, which is the nipple and the dark skin around the nipple on both sides. Or they can take tissue and make a nipple and put it there. So these are all possibilities for the people I do reconstruction with. Now, there are certain things that the plastic surgeon may say, oh, I don't want to take a chance with you. If they're a diabetic, that's really one of the things that really scare them away because diabetics heal totally different. So they may say, let me let you go. We'll let Dr. Jones do the surgery. I'll come back later and we'll put implants in and we'll put the spacers in. Or they may just put the spacers in. And then over time, they expand the spacers to a size that works for the lady. And then they come back and put the implants, the permanent implants, under that. So that happens too. We get some of those where the plastic surgeon just says, this patient, or you can't stand the length of the surgery. And they said because the deep surgery is like an additional 5.5, 6 hours many times. So some people can't tolerate that length of surgery at the time they have their mastectomy done. So we would close it, put drains in, and then later they'll address that. So that's the reason why it's different for everyone. As I said earlier, every treatment is tailored to the patient.
There you go.
Dr. Jones,
Okay.
someone asked the question, why would Monique have to have chemo, although she elected to have a double mastectomy?
As I mentioned earlier, no, if you have breast cancer, and that's invasive breast cancer, we always do genetic, molecular genetics of the tumor itself. And if that tumor, the molecular genetics says that this tumor, this patient will do better if they get chemotherapy, we give chemotherapy. If it says this patient will not benefit from chemotherapy, we don't give it.
So does it have anything to do with the possibility of it metastasizing or spreading somewhere else?
You mean needing chemo? Yes, because
Needing
that data says the 5-year probability of local recurrence, 5-year probability of distal recurrence, 10-year probability of distal recurrence, all that comes in the molecular genetics report. And if it says this person has a high risk of recurrent disease, that discussion is held with the oncologist and the patient. There's some patients who just say no, but you've got to listen. You've got to work them through it. They've got to go talk to other ladies. That's why we send a lot of our patients to Sisters Network. We keep their number. And we said, call this person, talk to this person who has had it, find out why they chose that. And many times another African-American woman talking to another African-American woman about the unique things that happen when you get chemotherapy, if you so, desire, or you're taking an anti-estrogen. Think of what estrogen is supposed to do. Now you're taking something that's going to block estrogen, the hot flashes, the sweats, the dryness. I mean, there are side effects.
Yep.
And these ladies can talk to each other about it.
Yeah.
I'm a physician, I'm a man, I'm telling you, no. I send you to another African-American woman. Historically, that's who we see a lot of. And they can get down and do their real talk about, hey, girl, this is how you're going to feel, but this is how long it's going to last. It's going to get better. Tell your fiance or your husband or whatever, hey, this is temporary. And they got to work through it. And that's important too. When somebody has breast cancer like that, the person that they're in a relationship with, husband, fiance, boyfriend, whatever, that person has to become a part of that treatment process.
Yeah.
Yeah, I try to make sure men understand that, I kind of equate it with them. It's like, okay, how would you want your wife to deal with you or your significant other deal with you if you had your testicles removed, if you had orchiectomies? How do you feel about that? I mean, you looking to share your pain with, your significant other, your spouse? Just imagine what they're going through.
Yeah, speaking of which, Monique, can you talk about your recovery process, both physically and emotionally, and were there any unexpected challenges or triumphs?
It was a lot because even though I had, support is the best thing that anyone can have, and that's why these organizations and these foundations are so important for women. They really are, especially women of color. For me, it was hard because I also had to dealt with personally the wise me without anyone knowing. But I also felt like, it took a part of me that you have to kind of gain that back. I don't sleep well still at night to this day. I do take things because I have hot flashes and my body would just feel like it was burning at night. So it was something, unfortunately, it wasn't the worst thing, but it was something that was different. And we know that we don't like different things. So I had to find a way to adjust to it. The good thing for me was that I had a wonderful support team. I had a friend at the time that came in my life to actually help through everything. So I didn't feel, with the losing my hair and now I'm bald and now I have no eyebrows and no eyelashes. For a woman, you feel unattractive. You feel not wanted. You feel like you are the odd person in the room. So it took a lot for me to get that self-confidence back and to gain it. And it definitely helped with having the support. So the triumph was that I was able to do it a lot faster than others and embrace it faster so that publicly people could see it. And that kind of helped other people along the way that I would meet and that would come to me.
Yeah, knowing you, Monique, I remember, you've been involved in Sister Strut for so long. By the way, if you're not familiar with Sister Strut, it's a fundraiser that iHeartMedia does with the sponsors. And the beneficiary of that initially was Sisters Network. And since Monique has started her foundation, now the Pink Queen, I heard the commercial today, Monique. That's how I
Yes,
can
well,
say it.
it's still the Sisters Network, and we sister together.
Right. And I heard that. So, but when she talked about, being in an entertainment business, being such a visible person and already involved in it, and they're like, wait, what? Now I am the person that I have been working with, raising funds for so many years. So that's amazing that when I talk about, the triumphs and all of that, a triumph for me is that you have reached the 5-year mark and you're able to offer that support to others. And I love what you said, Dr. Jones, that a woman who's gone through it is such a good support to someone who is about to go through the experience. We're going to pause just for a moment. Don't go anywhere because Tyrone always does his homework for us. And we are going to do a history maker moment. It's only going to be a minute. So grab a bottle of water or just take a break. And we'll be right back as we wrap up the discussion. Take it away, Tyrone.
Hello, and welcome to Pause for the Truth History Makers Minute, October 8th, 2024. Today, I'm thrilled to share the story of Dr. Olufunmilayo Olopade, a true trailblazer in cancer genetics. Dr. Olopade's journey is nothing short of inspiring. She began her remarkable career in Nigeria, driven by a passion for medicine. After earning her MD from the University of Ibadan, she faced the daunting challenge of moving to the United States to further her studies. But with determination and resilience, she completed a residency and fellowship at Cook County Hospital in Chicago. Fast forward to today, Dr. Olopade is a professor of medicine and human genetics at the University of Chicago and the director of the Center for Clinical Cancer Genetics. Her groundbreaking research focuses on the genetic basis of breast cancer, especially in women of African ancestry. She identified specific genetic mutations that significantly increase breast cancer risk in this population, a discovery that has monumental implications for health equity. But her impact doesn't end there. Dr. Olopade is a fierce advocate for diversity in clinical trials and the broader medical community. She's committed to mentoring the next generation of doctors and scientists, ensuring that the future of healthcare is both inclusive and innovative. Her accolades are extensive, from the MacArthur Genius Grant to her election to the National Academy of Medicine and numerous publications in high-impact journals. Dr. Olopade's work continues to transform breast cancer research and healthcare, leaving a lasting legacy of hope and progress. Thank you for joining me on this History Makers Minute. Until next time, keep seeking the truth and celebrating those who make history.
Wow, Tyrone always surprises us. Good history maker, Tyrone. Dr. Jones, I want to talk a little bit about life after treatment. What follow-up care and lifestyle changes do you recommend to reduce the risk of recurrence?
Well, I mean, if the tumor is estrogen receptor positive, we know we have medicine for that. to try and prevent the recurrence. If the tumor is estrogen receptor, I said positive. If it's positive, we have medicine. If it's negative, we have no what I would call tumor suppression therapy, because it's usually an anti-estrogen, and the tumor doesn't like the environment of estrogen to grow in. So lifestyle, changing diet. Some people, the data is not all in, moving more to plant-based diets. Also, if you're obese, to work on weight reduction. Those are some of the things that can be done. And making sure you do surveillance. Now, if you only had one breast removed, remember you have the other breast, you have to have a mammogram on that breast. If you've had bilateral mastectomies, I always tell people, continue to do the examinations primarily in the armpits, because that's where many times you could have breast tissue, latent breast tissue up there that was never removed, because if you didn't need to have a lymph node dissection, you're not high up into that part of the breast. So I tell people, even though you've had a mastectomy, do breast self-examinations in the armpit part of both breasts, at least once a month. That should be part of your monthly breast exam.
Thank you. Thank you, Dr. Jones. Monique, what advice would you give to someone newly diagnosed?
Wow.
Oops.
Uh-oh, we lost her. Oh,
Hey,
no.
while we're waiting, Ken, did you have a group of slides you wanted to show?
No, I'm okay. I wanted to have a discussion if people ask questions,
Right.
just to use the time up with questions. And somebody had asked earlier about genes. We had talked about the BRCA1, we talk about the BRCA2, and there we do some other testing. And it's called PALB2, which if an African American women with that gene have a 58% lifetime risk of developing breast cancer.
Wow.
So when they do the genetic testing, if you're PALB2, which is PAL, big B and a 2, if that gene is there, that's when you start discussing possible prophylactic mastectomies. Bilateral, yes. And there's so many things that we look at. If someone has BRCA1, BRCA2, and if you carry the BRCA2 gene, we know that if 1 and 2, we know that you have like a 48% chance of developing breast cancer over a lifetime. And so you treat the lady different. We talked about the other 2, the CHEK2 gene, which is another. When you do that genetic analysis, you get all these things back. You get CHEK2, you get PALB2, all these are coming back. But you want to know, well, what do I do with them?
Right.
And
What
you
does
give
it mean?
the data. If you've got CHEK2, then you are like a 30% chance of developing breast cancer. Some ladies may say, that's way too high for me. I'm out of here. And they want a mastectomy. So as I said before, all treatment is individualized.
But Dr. Jones, it seems that those genetic testing, and hopefully we can get Monique back in to share her thoughts. But it seems that the genetic testing, though, is not available until you get a breast cancer diagnosis. It would seem that it would be helpful if insurance companies would allow for a woman, at least a woman who has a family history of breast cancer. And by the way, I learned recently that because my dad had prostate cancer, I now have a risk of developing breast cancer.
Breast cancer, yes.
Yeah. And so it would seem that the insurance companies, and maybe that's the reason why you don't get genetic testing, is because insurance companies won't pay for it.
So because if you were to pay for it out of pocket, they're not cheap. You're
Right.
looking at over $1,000 or more. So many patients, if you have a strong family history of breast cancer or the associated cancers, say all the men in the family had prostate cancer and 2 sisters already had breast cancer, you then have to send a request to the insurance company to have a request for BRCA testing or breast genetics. So you'll get BRCA1, BRCA2, PALB2, CHEK2, ATM, all these other genes they would look at that put you at high risk. Now, when you get that result, the question is, what do you do with it?
Right.
We know definitely what BRCA1, BRCA2 will do. We know that, if you have the PALB2, 58% chance, you want to live with that? Probably not. If you've got CHEK2, 30% chance, you want to live with that? I don't know. So here we go. Once that comes back, in what way is the patient and the physician and the treating group, because now you don't have an oncologist now, you have to go have a meeting with a geneticist, and you have a meeting with the oncologist, then you have a meeting with the surgeon. The insurance, and again, many insurance companies will pay for that if you have a strong history. But remember, before the Affordable Care Act, a lot of these people had no insurance. So even if you wanted it, you couldn't get it.
Mm-hmm. Mm-hmm.
So when people talk about, and not to get political, when people talk about destroying the Affordable Care Act or whatever, they want to slap it to Barack Obama's name or whatever, that's all politics. We're talking about healthcare. And we look at healthcare, if they're going to be able to get the healthcare. And that's why we're seeing a lot of people who never had a mammogram, couldn't afford it. The Affordable Care Act came in, they got the subsidies, they came and got a mammogram, they had disease. Now, in the old days, they would not have had one until they had a big mass in the breast, and they show up. And then you're trying to get free care in multiple places, when for what they're paying with the subsidy, they now have the ability to get their diabetes taken care of, to get a colonoscopy, to get their mammography, to get their, everything. And so the overall health care of the community will improve if we make people available and make these services available to people in the community. So we continue to see disparities in care because, one, we've got to make sure that free mammography van goes to the Black side of town. Somebody has to say, you know what? We need to take that van over in 08 or 09 or wherever and say, because those people don't go to the doctor if they don't think about it. They're not going to go for a mammogram, if they don't think about it.
One of the things that what I'm hearing from
I want to go back to Monique, since she's back on, to answer the question. She didn't get a chance to answer. Her advice to someone who's newly diagnosed, if I could.
Okay, I'm sorry, cut off again. I just was faced with this yesterday, and the first thing that I said, I know you're scared. Everyone's scared of the unknown, but look at this as just something that has come up that has to be handled. And just like when we prioritize our bills, we know the light bill needs to be paid before anything else. If we're only down to our last $500, whatever it may be, because we have to keep the lights on, we have to see, we need our water, we need electricity to keep the refrigerator going. This is something that takes a priority, or maybe over something you had to do next month, maybe taking care of someone else. Put it first. This time, even if you have children, put it first. If you need help putting it first, call a friend, call an organization. If it's something you don't know, if you're afraid to go by yourself, or maybe you don't want your spouse. There's a lot of women that don't want their husbands to know it first, or their boyfriends to know that this is happening. Then take someone with you. I make myself available always to go with someone that just finds out. And listen to the doctor. Listen to your options. Don't rush into your decision. Don't take too long, but know that you're making the best one for yourself. Don't make it for everyone else. Make it for you. And know that you can get through this, and you will get through this. It just takes time. And also know that you have people that are here to help, and resources. Even when they say you initially have to come and you have to have a certain amount of money that you have to pay to the hospital. I can't afford this. I can't afford that. Resources. That's why you have the Sisters Network. That's why you have the Pink Queen Bee. Just being an advocate and a person to say, and I went through it also, and I had the same fears, worries, and questions. And that's why I'm here with you. So it's just reassuring someone that it's okay when you're diagnosed with this. We're not in 1960 or 1950 where it's like, okay, this happened, there's nothing we can do for you. There are a lot of things that we can do. There's a lot of research and studies being going on. The only thing that I would say that to them, but the only thing that I would say to the doctors today, and I can't fight the fight alone and I don't have all the answers. I'm learning as I go. I wish that the legislation would change the laws. We're worried about Amendment number 3 and being able to make marijuana legal and being able to carry guns and all these other different things. But why are we not fighting to raise the age that the healthcare will allow women to have mammograms done so that they can have early detection that way as well?
You mean lower the age so they can get it soon?
Yes.
Okay.
Yeah,
Yeah.
that's the kind of stuff we have to take our elected officials, those folks who show up in front of us. Dr. Jones, I am going to talk politics. Those folks who show up at us to us and ask for our vote, we have to have our list ready. Okay, so if I vote for you, here's what I want you to. The first thing I want you to do when you're elected, and we've just got to really start holding people accountable. So great advice, Monique, and thank you for that. As Dr. Jones says, there's nothing like having someone who's gone through it to have a conversation with someone who is now having to go through it. We're past 7:30, but Dr. Kane, we're going to give you an opportunity, the two of you, an opportunity to give your final thoughts. But Dr. Kane, you were going to say something a few minutes ago.
Well, I can give it in my final thoughts.
Okay. So, what is one thing, and this is for both of you, what is one thing you wish more people knew about breast cancer?
I'll let Monique go first.
Basically what I always say to them, I wish the one thing they knew was that you can fight. Don't doubt yourself. Don't doubt the disease. Every day people are doing things so that we can live through this, and we will live through it. And just be a fighter. Don't give up.
And know that there are resources available
There are
for
resources available. I'm a phone call away 24 hours a day for anyone that would want to talk, or that they're going through this, or would have a question, or that wants to pray. There are people out there that will walk you through and help you.
And if you could put in the chat, Monique, how to reach the Pink Queen Bee Foundation, that would be great. Dr.
Absolutely.
Jones, what are your thoughts? What do you wish more people would know about breast cancer?
That the majority of ladies and the 1% of men who are diagnosed with breast cancer, the majority of patients are alive and doing well after chemotherapy. And whether they have surgery, a mastectomy or a lumpectomy, whether they get chemotherapy, whether they're taking medicines to suppress it for 5 to 7 years, the majority of patients with breast cancer live. But if you delay it, and that's the important piece, early detection, get your mammograms, do your breast examinations, understanding your family history. There's some people get until they're 35 and 40 and found out their great grandmother had breast cancer, their grandmother had breast cancer, their mother and a mother's sister. Because in the old days, people didn't talk about that stuff. So they find out after the fact. Well, my goodness, I should have been more attuned to early screening and early detection because of my family history. Or maybe I should have gotten my BRCA testing or breast cancer, detection genetics early. Advocate. You've got to advocate for yourself, and we have to empower the organizations that advocate for women to understand breast cancer, work with them, help them through the process. I know that was a lot of stuff, but I just
No, that's good. Good stuff. So we're past 7:30 and we want to respect your time. So we would like to give both of you an opportunity to share your final thoughts. Monique, I'm going to start with you because I also want you to do a public service announcement about Sister Strut. So in your final thoughts, can you share your final thoughts regarding understanding breast cancer from diagnosis to, to recovery? What are your final thoughts? And again, share, we have your foundation up, Pink Queen. Is it Pink Queen Bee or Queen?
Pink Queen Bee.
Pink Queen Bee Foundation.org, Tyrone. And that's the letter B, not BEE, right?
Yes.
Just the letter
Yeah.
B. So,
Yes.
go ahead, Monique. Tell us your final thoughts.
My final thoughts would be from the beginning. In the beginning, take it day by day. Know that there are people that are there to help you. You have great doctors. Look at your resources. A lot of times we don't read the ingredients of anything that we buy. We don't really look into things. We just kind of go into it not knowing what it is. You have to know what it is. You have to know what you have, and you have to learn how to deal with it. And you have to learn how to get through it so that you can help others and so that you can stay healthy. And once you get through it, find ways to cut your sugar, to change your habits, and to live a better lifestyle so that you can live longer. For more information, definitely this Saturday, we're still doing Sister Strut. It starts at 9 a.m. at the baseball fields, 121 Financial Ballpark Center. And also on 10/26, the Pink Queen Bee is having their first Thrive Empower Her Expo. It is totally free. It is for survivors. It's going to be at the WJCT Center, and that is going to start at 9 a.m. until 3. And we encourage all survivors to come out and just receive, you listen to speakers, work out, meet other survivors like yourself, talk, love, have takeaways, and just educate yourself and just learn and just party and celebrate for being here still. So that's that's my takeaway on. I look forward to seeing everyone there.
Thank you, thank you, thank you so much. Dr. Jones, what are your final thoughts?
My final thoughts are for women, but the African American diaspora is that we start selecting primary care doctors that have our interests at heart. We have good documentation that when African American patients are cared for by African American physicians, the outcome is better. That's well documented, and there's not a question about it. So, my perspective on it is that we need to establish excellent, close relationships medically with a physician who may think like you, who may look like you, who may be in the same environment that you're in. So, selection of the correct primary care physician starts one. And once we get that good relationship working, you will get your mammograms, you will get your colonoscopy, you will get, your blood sugars managed and everything else. So it's that I look at when we make these decisions. You're not just a breast cancer patient or a colon cancer patient. You are a patient of a physician. And that physician's goal is to keep you around here as long as possible in the best shape as possible. And that physician will also help you with food choices, talking about changing diets, why a changed diet may improve your life. So that's what I said. Getting and establishing a relationship with a physician who cares about you and who interacts in your community.
And my thoughts, these are not my final thoughts, but just to piggyback on Dr. Jones for our listeners who have not decided, if you're in college and you haven't decided what you want to major in, consider being a general surgeon, because Dr. Jones is not going to be a surgeon here much longer. He talked about being a surgeon. How many years, Dr. Jones?
48 years.
So 48 years. So he's not the youngster that he was 48
I'm
years
looking
ago.
for a replacement right now. Can't find anyone.
So,
Unfortunately, some people don't want to come to Florida, and they said there's too much politics mixed in with medicine. And then, of course, trying to find someone who appreciates the community I work in.
yeah,
That's
yeah,
very important. You've got to
yeah.
respect that community if you want to take care of that community. So, if anyone is listening and they know a surgeon who doesn't mind relocating to Jacksonville, Florida, and having an office on the north side and an office at Ascension, give me a call, please. We're
Thank
looking
you.
for you. It will help my retirement a great deal. I can retire
Y'all
feeling
feel
good about
guilty, right? Yep,
that we've
yep.
transitioned the patients and not just left them like that.
Absolutely, absolutely. Dr. Kane, what are your final thoughts regarding tonight's topic?
But what both of you guys, all of you guys just said, perfect lead into what I was thinking. It's like, it's a shame that we're going to lose such a brilliant mind about these medical issues that we have, especially as it relates to breast cancer, that we would lose someone like Ken to go out and have a great time golfing or whatever else he wants to do. You know, the community will suffer. You know, Ken may be having a great time, but you know the lead I want to get, the lead that it gave me was that, you know, breast cancer is a very complicated disease. It's difficult for some physicians to understand all the parameters and all the options and all the issues that women may go through in terms of trying to diagnose and treat this disease. It would be great if we had a person like Ken who remains around as a physician advocate. Maybe he don't do the surgery, but he can be a physician advocate for patients. Doesn't mean he doesn't have to do it for free, but I would be, as an individual, I'm always happy to pay for some services that I can't do myself. Okay. If it's building a house, if it's fixing my car, if it's whatever it is, I have to go and pay for those services. Someone like Ken, whom around to help ladies matriculate through the difficult path of, you know, breast cancer, diagnosing, what prevention, diagnosis, and then the treatment. We need that kind of person around to remain around to help, to help guide our community and the ladies in our community through their breast cancer issues or breast issues. So there's also any physicians around who are looking to become physician advocates, wink, wink, Ken, physician advocates for patients. That would be a great thing to have out there available in the community, because I don't think we got it. It'll be a person who's neutral to a facility or health insurance or anything. They are there primarily for the patient. I rest my case.
Thank you. Thank you, Dr. Kane, Dr. Jones, and Monique. Breast cancer is a journey that affects each person differently, but through early detection, informed decision-making, and a strong support system, recovery is achievable. We hope this conversation has given you not only a better understanding of the medical side of breast cancer, but also the emotional resilience required to navigate it. Whether you're a patient, survivor, or supporter, know that you're not alone. Resources and communities exist to provide support at every step. We encourage you to prioritize your health, stay informed about your options, and never hesitate to reach out for help when needed. As our guests reminded us, courage, hope, and education are powerful allies in the fight against breast cancer. Stay strong, stay proactive, and remember that every story of survival brings hope to others on this path. Thank you for tuning in. Have a good evening.
Thank you.
You see why you need to tune in every Tuesday at 6:30 p.m. Eastern Standard Time. It's been an absolute joy having you with us today on Pause for the Truth. Dr. Rogers Kane and Ms. Jocelyn Turner are so grateful for your time and support. We know you have a lot of choices, and we're thrilled you chose to spend your time with us. It means the world to us. A shout out to Tyrone Jackson of Call Tyrone IT Services for making everything run smoothly behind the scenes. Tyrone, you're truly a whiz. Remember, folks, we're here every Tuesday at 6:30 p.m. Eastern Standard Time with more insight, stories, and truths. So mark your calendars, set those reminders, and join us for another exciting episode. Thank you once again. And we can't wait to connect with you next week. Stay curious, stay engaged, and most importantly, stay tuned.
Can anyone
Don't
see
forget
me?
to like us on Facebook, link with us on LinkedIn, and most of all, subscribe to us on YouTube. Never forget to pause for the truth. Thanks for your support. Have